Okay, so Ala or Fadl, are we ready to go live?
Yes, we're live.
Yeah, can we let the people in?
فتحوه.
So, Dr. Merfat, you lead us. When do you want me to start?
I think maybe we start, and if people want to trickle in eventually, that should be okay.
Okay, thank you very much, Dr. Merfat, for really putting this webinar together. And thank you all for participating, our dear speakers and presenters. It gives me really great pleasure at the National Heart Center to welcome everybody, all our speakers, panelists, and participants in this important webinar. The National Heart Center is part of, or a center located at the Saudi Health Council in Saudi Arabia. As part of our mandate is really to identify innovative procedures in cardiovascular medicine, shed light on them, open doors for discussions, and identify how we can move forward in really utilizing these innovative therapeutic options for our patients. Today, we're going to talk about atherosclerosis and a novel bioadapter treatment that restores vessel function and may endorse plaque regression. I will leave now the floor for Dr. Merfat to go further and explain more about how are we going to go through this evening, and also to go through the speakers and their biographies and what are they going to talk about. So I'll leave the floor for you, Dr. Merfat. Go ahead.
Thank you very much, Dr. Tash, and thank you to the National Heart Center for these opportunities to really explore novel therapies. What we're going to try to do today, our panelists very quickly are Dr. Wael Kashkari, he's the president of the Saudi Arabian Cardiac Interventional Society, Dr. Nawf Al-Anazi, she is an interventional cardiologist at King Saud University in Riyadh. The agenda for today, we're going to discuss the burden of cardiovascular disease in Saudi Arabia, and I'm going to be presenting that segment, and I'm the General Secretary of the Saudi Interventional Society. Major adverse cardiovascular event rates in patients in Saudi Arabia. This will be presented by Dr. Khalid Al-Shaibi. He's the director of the Cardiac Center of King Fahd Armed Forces Hospital in Jeddah, Saudi Arabia. Next is going to be Professor Antonio Colombo. He does not really need any introduction. He is a very senior interventional cardiologist and has shaped a lot of our practice. And practicing in Milan, Italy. He is going to discuss restoring vessel function with the Dynamax bioadapter technology. Then we move on to Dr. Johan Bennett. He is also a very senior interventional cardiologist in Belgium, and he's going to go over the randomized trials of sirolimus-eluting bioadapter scaffolds versus the sirolimus-eluting stents, 12-month results. And then we're going to close off with real-world data and the Saudi experience with bioadapter with Dr. Samih Lawand, who is also an senior interventional cardiologist at Dalla Hospital, Riyadh, Saudi Arabia. So without any more delay, what I'm going to do is really go ahead and get started with the presentations. And I guess I'll start with mine. Can you see my slides?
Yes.
Yes.
Okay, perfect. So I'm going to try very quickly to go over the burden of cardiovascular diseases. I want to start by going over the executive summary that was prepared by the National Heart Center and published about a year ago in March of 2022, looking at cardiovascular disease and why they decided that cardiovascular disease is a public health priority. So when we really look at this, there is an urgent need to address cardiovascular diseases in the kingdom. Public health strategies across the whole population will deliver far-reaching benefits for this and future generations, and that's the main role. Why is that? Well, because over 30% of the adults in Saudi Arabia, that is those over the age of 18, are at risk of an atherosclerotic cardiovascular disease event. 42% of all deaths are attributed to cardiovascular diseases in the kingdom. And when we actually look at the number of deaths resulting from coronary disease and hypertensive heart disease in the Middle East, it's about 309 per 100,000, compared with North America, where you're looking at 204 per 100,000, and Western Europe, which has a rate of 187 per 100,000. Equally alarming is that 60% of the Saudi population aged 35 years or younger, the net result in KSA, patients will end up suffering an atherosclerotic event on an average 10 years earlier than Western cohorts. And I think we'll probably get into that in Dr. Shaibi's presentation momentarily. But the burden of cardiovascular disease results in disability or years of health life lost because of disability in KSA in 2017 was 10,900 per 100,000. And the number of DALYs from ischemic and hypertensive heart disease in KSA is about 3,700 per 100,000. So that's quite significant, again, when you compare it with our counterparts in Europe and North America. So 49% of those between the ages of 61 and 75 are categorized as high risk here within the kingdom. We do recognize that a lot of them are non-compliant to lipid-lowering therapies. I'm going to get momentarily into why lipids are an issue in our part of the world. And only 28% of clinicians are actually aware of LDL guidelines and targets. And so 60% of the patients receiving statin therapies and so on, and lipid-lowering therapies, are actually inadequately controlled. So this executive summary gives us a model that tells us what we can improve, and if we do, what improvements we can find. And why do we need it? Well, it does come at a cost for the public sector. There's about over 11,000 Saudi riyals per patient over 5 years that is increased because of our failure to control primary risk factors at the primordial level. But all these interventions will ultimately lead to an 8-fold increase in achieving the target, LDL targets, and so 92% reduction in LDL. This is, again, modeling. But this is very important, and this is, again, the same concept that I actually told you. So in Saudi Arabia, the cardiovascular diseases is expected to increase by approximately 480,000 by the year 2035. Which is a 3-fold increase in the economic burden in Saudi Arabia. So you're going to go from 36.75 billion to 9.8, which is the equivalent of 9.8 billion. Currently, it's about 25 billion. The benefit of decreasing cardiovascular disease risk through targeted policy solutions, as recommended in this policy, will improve the health of everybody. So really quickly, this is the published in JACC in 2017, again reaffirmed in 2020, this similar authors. The leading cause, when you look at the Middle East segment, you see that 18 million cardiovascular deaths worldwide, and the majority of them are actually cardiovascular, with ischemic heart and ischemic stroke being the majority of them. Compared with the 6 Gulf Council countries, Saudi Arabia actually has the highest death rate, despite the fact that actually Saudi Arabia has the highest expenditure on healthcare compared with Kuwait, UAE, Bahrain, etc. And why is that? So now I'm circling very quickly back to the risk factors. About 1/2 of the Saudi population have 3 cardiovascular risk factors. A quarter has 2 risk factors, and the leading risk factor is dyslipidemia compared with hypertension, smoking, and diabetes. The most important information that we got was from the Pure Saudi sub-study that was published very recently, about 2 years ago, looking at it in terms of overall population or men and women, quite high for all of them, but significantly higher in terms of smoking, more so in men compared with women, but women were more likely to be obese. Again, when you look at the different age brackets, across all age brackets, you do see very high risk factors, more likely in 60 to 70, but astonishingly, the risk factor is 35 to 49, that is the youngest age group. You can actually look at them. The number of risk factors are still high, especially smoking. And finally, urban versus rural. Well, most of the risk factors are higher in the rural communities, except for in urban, as expected, an unhealthy diet and a little more smoking. So the interventions that we're hoping are going to be successful will reduce MI, revascularization, ischemic strokes, and quality of life, and so on. And again, you look at the green and blue bar, and you're looking at an improvement in terms of the green bar in terms of outcomes. So hopefully there will be fewer deaths by the calculated model and non-fatal cardiovascular events. These are the different interventions and the different layers. I'm not going to bore you with them. The executive summary is available online. But ultimately, again, what you're looking at is you want to see the green bar over here, the interventions at the lower brackets of LDL, for example, are actually higher now than they were in the past. Which takes us to who we are. This is also endorsed by the Saudi Interventional Society. We're interventional cardiologists. What have we done? Well, we're really expanded what we do in the cath lab and not just outside the cath lab in terms of identifying plaque, calcium, deep calcium, and superficial calcium, and looking at what stents do. And unfortunately, yes, we do know there's a risk of neointimal hyperplasia and neoatherosclerosis despite all our efforts. We've looked at different types of stents and strategies, and we've looked at, these are bioabsorbable scaffolds that were implanted in the past. And again, you do see in-stent restenosis and late lumen loss in these as well. And so that's perhaps a segue to what's going to come next. And I'll quickly stop over here and turn it over to you, Dr. Khalid, to give us a little overview of MACE rates in Saudi Arabia. If you could just...
Thank you very much, Dr. Mirfat. I'll just share my screen. Okay, can you see my screen? So I've been tasked with talking about MACE rates in Saudi Arabia. Well, what is MACE? We're pretty much all interventional cardiologists. We know MACE stands for major adverse cardiac events. And usually when we talk about MACE, it's in the context of adverse events following an intervention, whether that intervention be a PCI or a bypass operation. Unfortunately, there are no Saudi registries that are published on PCI or CABG for that matter. And this highlights an important area that I think the Saudi Health Council can lead. And we desperately do need national registries so we know the results of what we're doing and providing to our patients. But assuming that most PCIs are performed in the setting of an acute coronary syndrome, whether that be a STEMI or non-STEMI, I looked at the regional published ACS registries and reviewed them to see if the proposed question of MACE can be at least partially answered by looking at this registry data. And if we look over the past 13 years, actually, there have been 7 published registries within the Gulf that have addressed acute coronary syndromes. Starting from 2005 with the SPACE registry to the most recent that was published in 2019 and enrolled patients between 2015 and 2017, and that was the STARS program led by Dr. Khalid Al-Habib. And I'll take that, since it's the most relevant and the most contemporary data, to take a closer look at and see where we are. So the STARS program was a prospective snapshot design it was designed to be repeated every 5 years. It enrolled patients with STEMI or non-STEMI greater than 18 years old. It involved 50 hospitals, representative healthcare delivery in the Kingdom of Saudi Arabia, 60% Ministry of Health hospitals, 30% from the private sector, 10% from the military, National Guard, and university sectors. And enrolling hospitals were distributed throughout all the administrative areas of Saudi Arabia. The follow-up was clinical follow-up at 1 month, 1 year. The STARS 1, which I'm reviewing with you today, enrolled patients between 2015 and 2017. STARS 2 has completed enrollment, and I'm told will be published later this year, probably in September or October. So what did we learn from STARS 1? So as Dr. Al-Asnach pointed out, our patients that present with acute coronary syndrome do at a much younger age than most Western societies. So the mean age at presentation with an ACS was 55 years old, a little younger for STEMI and a little older for non-STEMI. A very young population. And again, as was pointed out by Dr. Mirfat in her overview of the burden of disease in Saudi Arabia, as you can see here, risk factors were extremely prevalent. Over 50% of patients had diabetes, hypertension, and were current or ex-smokers, and about a third had hypercholesterolemia. So again, a young population with a very high prevalence of known cardiac risk factors. Now, if we look at STEMI, and this was present in the STARS 1 program, we identify another issue that I think we need to pay attention to. I'm straying a little bit away from the topic, but I think it's important to point out here. And again, it's an area I think the Saudi Health Council can help with. If we look at patients presenting with STEMI in the STARS 1 program, only 5% arrived to the hospital via an ambulance through an emergency medical service. 95% arrived on their own transportation. And this is also highlighted in this important statistic. From symptom onset to arrival at the healthcare facility, the median time was about 5 hours. So you can imagine 5 hours before they present for first medical contact. That is pretty scary. And if we look at the STEMI population in STARS again, and look at once they do present to a healthcare facility, how they are treated. 29% receive thrombolytic therapy. Remember this snapshot study, 60% of hospitals were not PCI capable hospitals. So thrombolytic therapy and subsequent transfer for facilitated PCI was the modus operandus. 42.5% underwent primary PCI, and actually close to 30% had no reperfusion therapy of any sort administered, primarily because of very late presentation. And what's important to note is actually this may look bad, but actually it is a significant improvement, at least over the past decade, from the space registry, which was the first ACS registry in the Gulf region. The rate of primary PCI was 17%. It's up to 42% in 2017 and 2019, and I'm very hopeful that the publication of STARS 2 in September or October of this year will show that we've made further progress in primary PCI. So this is again a representation of the types of therapy patients present with. Now, the STARS program, remember, looked at all patients presenting with ACS, whether it's STEMI and non-STEMI. So when we look at MACE events, which are covered by or can be looked at through the lens of readmission, most patients who have a MACE event will be readmitted to a hospital. And if we look at 1 year readmission rates, we find that they're in the range of 20% readmissions at 1 year for patients who have been treated for an ACS, non-STEMI or STEMI, irrespective of whether they were treated medically or received revascularization therapy. And the vast majority of these readmissions at 1 year were for cardiac causes. So they are, in the vast majority of cases, major adverse cardiac events that lead to rehospitalization at 1 year in patients treated for acute coronary syndrome. Like I said, though, this is not exclusively a readmission rate following PCI or CABG, but there's an all-comer readmission rate or an all-comer MACE rate, which includes those patients that may have been treated medically. As you can see, we certainly lack important data. And if you look at the 1-year mortality for the same group of patients, it's around 5%, a little bit higher for the non-STEMI population at 7%. So if I was to give you some take-home messages from my review of the available and very limited data available for Saudi Arabia, I'll reiterate what Dr. Mirfat has said. Given the prevalence of cardiovascular risk factors in the Saudi population, leading to early onset of cardiovascular disease presenting as an ACS, and the subsequent impact on years of healthy life lost due to disability, strategies aimed at early detection and treatment of cardiovascular disease risk factors is important. I know this is a main area of that the Saudi Health Council is addressing with its SLIPID program currently. But also, given the fact that only 5% of patients come to a hospital using emergency medical services, and the median time from symptom onset to first medical care is 310 minutes or 5 hours, there's clearly a need to establish national STEMI networks and invest in the emergency medical services to improve access to care for patients with ACS. And this must be coupled to a public campaign to educate the general population in recognizing the symptoms of AMI. And this, again, I think has started within the Ministry of Health, but still needs a lot more work. I think there's a STEMI network which is established in Riyadh now, but other areas of the kingdom have not had such networks established or in the process of establishing. So this is, again, an area where we can certainly improve. And then most importantly, more relevant to the talk I was given, I really can't answer the question of what is the MACE rate following coronary intervention in Saudi Arabia. And we must establish national registries for both PCI and CABG, so we know that our patients are receiving appropriate revascularization with outcomes that can be benchmarked to international standards. Thank you very much for your attention.
Thank you very much, Dr. Abi. Thank you very much, Dr. Mirfat. So this is the first part with two excellent talk by Dr. Mirfat and Dr. Chebbi. I would like from the audience, if they have any question, the door is open, and you can send us the question, and we can ask the two speakers, directly. I have a question for Dr. Mirfat Al-Asmaj. Clearly that the average age of coronary artery disease in the Kingdom of Saudi Arabia, from relatively the data we have, it is at younger age. We are seeing average of 50 to 60-year-old, and even we are seeing youngest. So what do you think the main reason for that? Is it we are like different regarding the lipid issue, or it is a multifactorial?
So it is multifactorial. It'd be nice if we could have some kind of genetic testing and to see it. I know that, for example, familial hyperlipidemia, they're looking into it. There's a registry right now, and there's more active research in that area. But one thing that we do know is, like from Jupiter trial and so on, is that when you do start treating dyslipidemia early in the 5th decade of life, so those who are in their 40s, you get the steepest decline in the hazard ratio for major cardiovascular events. So I think our problem is we're not treating these patients early. We're treating them quite late after they come with their first event and maybe even their second event, rather than working at the primary prevention level. And I think these are the initiatives that the National Heart Center is looking into right now, is to screen the population and look at the primary level, but then aggressive treatment of all risk factors. And the number one risk factor, as you well pointed, is dyslipidemia.
Dr. Adel Tash, since the National Heart Center started and established, I can see there is a major works going on lipid. Can you give us insight about it in 1 minute, please?
Sure. طبعا يعني there is يعني Dr. Shaibi pointed out very nicely that the about 50% or more than 50% of the population that presented from the space registry that presented with either a STEMI or a non-STEMI were diabetic and were smokers. And around 30 plus or 35 to 40% had dyslipidemia issues. But the concentration on dyslipidemia is on one hand, as Dr. Merfat mentioned, there might be, or we sense, or we can see that there is a higher percentage of our population that has genetic factors that may make them more affected by the heterozygous familial hypercholesterolemia. The other thing is the most important modifiable risk factor. I think the most important and easily modifiable risk factor that we could approach is dyslipidemia, and that's why at the National Heart Center we chose. And on the third note is that in Saudi Arabia I think Ministry of Health did a tremendous job on diabetes, and I think we are on the winning streak with type 2 diabetes. But for dyslipidemia, we didn't find any real work done there. So that's why we chose to target the most important modifiable risk factor for cardiovascular disease, which is dyslipidemia.
Dr. Nof?
Yes.
I just want to add one more thing for the registries. And I think this is an extremely important point that Dr. Shaibi mentioned, that we do need national registries. And I can say now very confidently that we already contracted the American College of Cardiology as a partner with the Ministry of Health to establish the NCDR registries in 2 pillars, which is chest pain and MI and PCI for all the Ministry of Health hospitals. And I encourage all our colleagues to join in and join the NCDR registry, either from the private sector, from the military hospitals, National Guard hospitals, university hospitals, security forces hospitals, King Faisal Specialist hospitals, anybody that wants to join with us. It's just the investment will be minor because we do have the big investment already there done in the cloud, in the national cloud, and the American College of Cardiology has a direct presence now here in Saudi Arabia with this collaboration. So I encourage everybody really to reach out. They can reach out to the National Heart Center. They can reach out to me personally, and we can add their center to the program. Tfadali, Dr. Nof. I'm sorry to interrupt.
We just have, I think, a few questions from the attendees. If we can answer at least some of them. I think one of the questions was using Vascepa as a medication to reduce the risk of cardiovascular events is probably not directly related to our webinar tonight, but we can quickly answer. We do have a study that came out a few years ago about the effect of using Vascepa, which is basically omega-3 at a dose of 2 grams twice a day. There was some evidence that using it in high-risk population who do not respond to statin and have high levels of triglyceride may benefit from adding it. And I think it did make its way to the guidelines and was added in the European guidelines as a class 2A indication. Further questions, I think, will be taken after the next talk.
So go ahead, Merfat, and introduce the next speaker.
Right, so I think our next faculty is Professor Antonio Colombo, and he's going to give us an overview of the bioadapter technology before we get into the evidence for that technology. So, Dr. Colombo.
Thank you very much. Let me share my screen. Can you see my presentation, first slide?
Yes.
Yes. I didn't
Yes.
hear. Can you
Yes,
see?
yes.
Okay, thank you. So I think we need to shift from prevention or medical treatment to a more invasive approach. This approach is really coming late, and we know that it's more important what you just said regarding cardiovascular disease and what I'm going to say. But nevertheless, we have to deal also with acute intervention. Restoring vessel function with a novel Dynamax bioadapter. This is a very funny name, bioadapter. What does it mean? Is that a new stent? Is a kind of a new stent, is a new concept that in many ways bridges between bioresorbable scaffold, a drug-coated balloon, and a permanent metallic stents. The background is that DS, drug-eluting stent, improved the first-year clinical outcome compared to bare metal stent. You see in the first part of this graph, target vessel failure in blue, bare metal stent in red and dark, the first and the second generation DS. But despite these advantage of DS compared to bare metal stent, on the right side of the curve, you see that the event rate at 60 months keep on increasing about 2% every year, reaching almost 10%. So why this happen? I don't know if I can give you the solution. It's progressive of the disease, but certainly the metal cage is not helping the physiology to counteract the atherosclerotic disease. And let's see why my statement may be correct. Stenting inhibits vessel dynamic compliance. Coronary arteries experience significant movement during each arterial beat, and disruption of the natural vessel dynamics can contribute to coronary artery progression, and there are studies supporting this statement. And the mechanical environment in the vessel wall is greatly altered by PCI and stent placement, especially, I would like to add, with the usage of very long stents, which is a very frequent practice nowadays, compared to the past where we had only 15 millimeter length DS or metal stent. And how stenting alters vessel dynamic compliance. Radial, because there is a radial expansion of the stent of the vessel, which is negated by the metal device, causing arterial artery compliant mismatch. Rotational, the coronary artery moves counterclockwise and clockwise during each beat. And angulation, we know the coronary arteries have severe angulation, sometimes we call excessive, but that's what Mother Nature gave to the vessel. And this bioadapter is designed to overcome this shortcoming of metal devices. And acute performance is similar to DS. As you will see, this is a metal device with the deliverability and implantability similar to new generation DS. giving high acute gain, low diameter residual stenosis. But something new happened at 6 months that enable vessel motion and functional response. There is early uncaging, and please be patient until the next slide, because you will understand what I mean for uncaging, which can restore pulsatility and compliance and increase blood volume delivered to the periphery. This provides dynamic support, maintains, but reduces arterial stress. You will see why. Improves hemodynamics with the systodiastolic pulsation, allows positive remodeling. This is a very important aspect, because positive remodeling is negated by permanent metallic implant, and this was a wishful thinking with bioresorbable scaffold, and enable lesion stabilization. But let's explain why this happened. This is a meta stent, and you see some U-shaped connection which are still open. Now these connections are attached from the blue to the yellow frame to create a solid scaffold. These two connective bodies are maintained together by polylactic acid, bioresorbable polymer that maintains the scaffold as a unit. But with time, the polylactic acid reabsorb. There is an early polylactic glycolic acid, which is a top coat to deliver drug. But I like to concentrate on polylactic acid, which when is reabsorbed, the link between the two cages becomes free, and the device is not anymore constrained in the radial diameters and gives the vessel the capacity to expand. You see now on the left the acute result, which is basically the same of a standard metal stent. And on the right, you see that there is a systodiastolic expansion after 5-6 months due to disconnection of these link between the yellow and the blue metal frame. This allows some longitudinal compression, which is usually not maintained, not given by standard DS or metallic, allows some torsion clockwise and counterclockwise, and reduces straightening of the vessel. So all of these attributes contribute to modifying the stress and changing the shear stress on the vessel wall by flow dynamics. And this is something theoretical, and not only it has practical consequences. So we conducted a study, and I was part of the study, to evaluate these mechanistic attributes in a clinical fashion. The purpose was to evaluate the safety and performance in de novo coronary lesion. This is a registry with a non-randomized consecutive enrollment, 9-12 months, with imaging, OCT, and follow-up to support what I will show you. 50 patients with single de novo lesion, reference vessel between 2.5 and 3.5, lesion length less or equal 24, standard DAPT. Diameters of the devices went up to 3.5, with the length up to 28. The overall principal investigator was Dr. Stefan Verheyen from Belgium, and myself in Italy, and there were 7 sites. Standard clinical endpoints the most important are QCA, late lumen loss, diameter stenosis at follow-up, and IVUS and OCT parameters that you will see later on. The follow-up extended up to 3 years. Quickly on the clinical data, clinical outcome, which is certainly not a major issue in this study, dealing with 50 patients. No deaths related to the device. We have 2 deaths, but they are not related to the coronary arteries. No thrombosis, so you see a lot of 0. No clinically driven TLR, except 1 late at 36 months, and no target vessel myocardial infarction. So overall, a clinical safe result. But let's go to the QCA data, which are the most important, and later on to the OCT. These are standard reference vessel, 3 millimeter, about 295 in segment, MLD in segment 251 at 9 months follow-up 239, diameter stenosis 14%, 17 at follow-up, acute gain 1.39, balloon artery ratio is about 1, and we see a very low late loss, 0.11 with a standard deviation of 0.16. And the contributor of this late loss, you will see later, is not only low neointimal hyperplasia, which is as expected, the same for most current low thickness DS, but is also due to late expansion of the vessel, positive remodeling, which does not occur with a standard metastent, but which is a unique attribute of this device. As a matter of fact, you see that in-device reference vessel diameter is 2.98, but some devices get bigger, the MLD 275, 263, and the diameter stenosis 5%, 7.7. And the late lumen loss, as I said, is very low, with a median late lumen loss of 0.05, which means that some lesions have really 0 late lumen loss due to the expansion of the device. And this is an OCT example. You see in a systole, the lumen area is 4.96. The biodaptor area is 6.05. And in diastole, due to the possible allowance, to the true allowance of pulsatility, the lumen area goes up to 5.65, and the biodaptor expands to 6.59. So there is a 14% increase in lumen area, and this translates not only in a gross mechanical gain, but in the delivery of a pulsatile flow to the periphery, which is maybe even far more important than the 14% lumen increase. These are additional measurements. You see the mean vessel area goes up from 14.11 to 14.54, 3%. The biodaptor area goes up 5%, and the mean lumen area basically changes 0% because there is an advantage due to remodeling. In blue, you see the result of an early study, 2010, published was the Spirit Science, where basically these numbers are not going up, but are staying the same because the DS is a permanent cage with a mean lumen area which goes down due to hyperplasia. This another feature is the vessel rotation, which rotates in both directions, clockwise in red and counterclockwise in grayish. And you see the excursion of the vessel treated with a bioadapter according to the cardiac cycle. And you see the difference. You see how minimal excursion you have with a caged metal device, standard DS, and on the right, the rotation allowed by the uncaged device. And this has an important fact because gives less stress on the vessel wall. So to conclude, this device, which has a different name rather than a stent, is a name that we like to call it bioadapter because adapts to the vessel physiology, effectively uncages the vessel to restore positive adaptive remodeling and maintain the vessel lumen, demonstrated by IVUS and QCA in 9-12 months. This is permitted by unique uncaging, restoring pulsatility, diastolic and systolic, and vasomotion. We did not go over this presentation regarding what happened with nitroglycerin and acetylcholine, but there are data that really clearly demonstrate the presence of vasomotion, which is not only present during pharmacology stimuli, but is also present during exercise, which is very important. Unique uncaging restores vessel compliance, vessel rotation, and allows the return toward baseline angulation. Again, this factor I did not show you any slide, but they are nice example of maintained angulation. And overall, despite the numbers I presented are small, only 50 patients, we have a very low clinical event. And I thank you very much for your attention. Just a final slide that highlights the fact that these 50 patients is just the beginning. We have completed another study in New Zealand, but more importantly, Dr. Shigeru Saito presented a PCR, a 445 patient randomized study, which gives enormous important data supporting the value of what I just said. There is a big study, Infinity, in Northern Europe, 2,400 patients, and a global registry of 5,000 patients evaluating what happened in real life. Thank you for your attention.
Yeah, thank you very much, Dr. Colombo. I just have a particular question. You know, when we're looking at, in principle, vascular function, and I think that was the concept behind the previous scaffolds, the bioabsorbable scaffolds, and we're continuing to realize that metallic stents, drug-eluting stents, are not sufficient to restore that, and we're hoping that technology does that. We know that particularly vulnerable populations are diabetics. So do you think this technology has any potential in the future for diabetic patients in particular?
This is a very, I don't dare to answer your question because I don't know. I think we will be able to address some of these questions when we will do subgroup analysis in the Swedish study and in the global market study. This data will be useful and comparable to the current data available with Metastent. Theoretically, I see some potential advantages. I do not see any negative aspect. But as we all know, what we think doesn't always reflect what happened in life.
I would like to ask a question, and this is a comment that I've heard recently, and I would like to hear your intake on it. It's an amazing technology, and it's very promising, and we're all with technology. The question is, do we actually have any strong evidence that losing these physiologic properties have adverse events in the long term that is worth going with this technology, especially that is probably triple the price of the current stents that we have?
Yeah, but the study of Dr. Shigeru Sato gives some clinical or indirect clinical data stating that this device has advantages. It's much more powerful than what I presented. But I think, again, we have to wait most probably another year or year and a half before getting data. But personally, I'm very fascinated by the positive remodeling. I think it's very important to allow the vessel to expand. And there's no question that this positive remodeling takes part. And I'm also fascinated by the vasomotion. I think the vessel needs to be able to pulsatile. All these attributes may not be so important when you implant a 12 millimeter or 15 millimeter stent. But when I see young generation that are so interventionist, who are so liberal to use a 40 millimeter device long, 38, and multiple stents, converting coronary artery in rigid metal tubes, I'm not happy about the metal property of standard DS.
Well, do you have any question?
Yeah, unfortunately, most of our patients in our region here, and I think in Asia in general, they have small vessels, diabetic, and diffuse disease, and you will end up by putting a long stent. So we are hoping with this new technology that we will be able to keep at least some of the physiological normality of the coronary artery when we need a long stent in this diffuse disease patient.
I'm very enthused by the question in diabetics. I think if there is a population where we need to get some improvement is diabetics. And I really believe we need a randomized study comparing standard DS, second or third generation DS, with this device and with the drug-coated balloons. 3 groups.
So when you decide to do this study, Dr. Colombo, involve us in Saudi Arabia. We'll be very happy. It's
I think
we are on the top of 5 diabetic population in the world.
I will be in contact with you because I really would like to do this study to give the last contribution in my career.
You're still young, Dr. Colombo. With all this, productivity, you are inspiring us, sir. All the best and healthy life for you, sir. It's a joy to watch and talk to you, sir.
Thank you so much.
So we'll move to the next speaker, Professor Johan, and another exciting lecture from a leader in the field.
Okay, can you hear me and can you see my screen?
We can see you, sir.
That's great. It's a pleasure to present this data, which Professor Colombo just alluded to. It was presented as a late-breaking trial in Paris just a few weeks ago at EuroPCR. And it's the first year, well, the primary endpoint of the Biodaptor randomized controlled trial. I won't go into too much of the background because we've just recently heard, or just in the previous talk, heard why we need a better treatment for our patients, because there's this increasing non-plateauing rate of target lesion failure from 1 year onwards after current DES implantation. The bioresorbable scaffold technology is promising, we know that. However, there's some Achilles heels, and unfortunately to date, they haven't proven to be safe and effective in the long run. So again here, this is the Dynamics Biodaptor scaffold, which you've just become acquainted with. Very briefly, it's comprised of 3 very thin cobalt chromium strands. It has got 2 layers of coating, a top coat which eludes the sirolimus, and then the base coat which absorbs over 6 months, and thereby allowing uncaging of the elements, as you saw briefly in the previous presentation. One thing to mention is that following this neointimal formation, the unlocked helical strands do still give some dynamic support to the vessel. So this is the randomized controlled trial. It was performed in Belgium, Germany, and New Zealand, and also in Japan. 445 patients were randomized to either the Dynamics Biodaptor or the Resolute Onyx DES. There was an imaging subgroup of 100 patients who had QCA in IVUS, and another smaller group of 20 patients who had OCT based at 12 months. The primary endpoint was target lesion failure at 12 months. It was a non-inferiority study. There's also secondary endpoints, which we'll discuss briefly in due course. Looking at some of the baseline characteristics, you can see here diabetes present in up to 30% of patients, which I appreciate is lower than the population we're discussing tonight. Prior MI also quite high. Smoking, 1 in 4, 1 in 5 patients. The age, again, older, 67-year-old in the Dynamics group. The main presentation mode was stable angina, though of course there were also patients with acute coronary syndrome. The LAD was most commonly treated. There also were some, although this was kind of a study looking at more simpler lesions, there were some patients with osteal lesions, bifurcation lesions, moderate to severe calcification was present in 1 in 5 of the patients, and also some tortuosity was present. The mean target lesion length was 15.8, though I think for an inclusion criteria was a lesion less than 34 millimeters. In terms of device success, you can see here very high acute device, lesion, and procedural success in both groups. The primary endpoint was met. So basically, the Dynamics Biodaptor was not inferior to the Onyx at 1 year, with a TLF rate of 1.8% in the Dynamics group versus 2.8 in the Onyx group. And the components of TLF also were not different between these groups. I'll just mention to you that the 4 patients who had TLR with the Dynamics, 2 of these actually were protocol violations and shouldn't have been included due to severe calcification, and also in a segment previously treated with a bioresorbable scaffold. Looking at some very interesting secondary endpoints, there was co-registered stationary IVUS performed to demonstrate pulsatility at follow-up. So basically looking at a percentage change in lumen area between systole and diastole using IVUS, which is recorded using the same frames at post-implant and at 12 months in 5 segments. 2 segments were outside the vessel, proximal and distal, and 3 segments were in the device. So what did this show? That acutely after implantation of the Onyx or of the Biodaptor, there was constraint within the device. You can see here in the middle, the percentage lumen change is about 2.7, 3.2%. Before and after the stented region, there was a quite normal luminal change in pulsatility. This is acutely. At 12 months, this constraint remained the same for the Onyx. However, in the Dynamics group, you can see here that especially the in the device segment, there was a much improved pulsatility, restoration of pulsatility within the device segment. When comparing the adapter in the proximal vessel to in device, there was no significant difference. So this whole vessel really shows this pulsatility, whilst for the Onyx group, as I mentioned, the in device is constrained, a significantly reduced pulsatility compared to the segment before proximal or distal to the stented segment. The change in blood flow, which was mentioned in the mechanistic study by Professor Colombo, was also looked at here. This was estimated using the Hagen-Poiseuille equation based on lumen area. And here we can see that the blood flow during the cardiac cycle was similar acutely in both groups post-implant, as you would expect. However, at 12 months, the flow was much improved, up to 16.7% improvement in the Biodapter group compared to the Onyx group. Looking at acute performance, we've mentioned the hope was that this would have an acute DES-like performance, and it really does. You can see here that the residual percent stenosis and acute gain are similar between the both groups, with no significant difference between them at all. Then looking at the diameter stenosis at 12 months follow-up, we can see here that there was less stenosis in the Biodapter group. And then looking specifically at LAD, small vessels and long lesions, this difference became even more pronounced. And as mentioned before, this is because of the vessel becoming larger, and therefore the knee intima is smaller and you get less percentage diameter stenosis. So significant improvement for the overall cohort with the Biodapter. When we look at late lumen loss, again, very similar. Overall, the late lumen loss in the Biodapter group for 100 patients was 0.09 compared to 0.25 for the Onyx group. And again, in different components, LAD, small vessels, and long lesions, there was a much improved late lumen loss. Looking here at volume of knee intimal hyperplasia, again, we can see at 12 months a significant lower volume in the patients treated with the Biodapter, and also less knee intimal obstruction. Whilst the OCT coverage of the struts was similar between both groups acutely and at 12 months. So just to show you these endpoint results, the primary endpoint of TLF was met with a TLR rate of 1.8% for the Dynamics and 2.8% for the Resolute Onyx. Acute performance was similar to metallic DES. And we can see here there was restoration of in-device pulsatility with Dynamics, significantly lower late lumen loss and percent stenosis, and lower volume of knee intimal hyperplasia. Just looking at a more novel finding, which I think will be very intriguing to discuss, the plaque volume change. And we're talking now about the plaque behind the device. If we look at the Onyx group, there was a 12% increase in plaque at 12 months. Looking at the Dynamics, we only have a 3% increase at 12 months, due to much less plaque present behind the stent. These changes in plaque were similar outside the stent area. So here, proximal and distal from the stented segment, you can see there was no significant change in the volume of plaque. And also just note that at 12 months, a similar amount of patients were taking this aggressive anti-lipid lowering medication. In non-calcified lesions, the plaque volume change was really quite striking. We actually can talk about plaque regression here, minus 4% in patients with non-calcified lesions treated with the Dynamics, compared to an increase in plaque volume, which we expect with most DES of 9%. This was even more striking in patients who had lipid-containing lesions, where there was a 9% reduction in plaque volume. So again, plaque regression in these lipid-containing lesions compared to a plaque increase of 10% in the Onyx group. So to conclude, Dynamics is non-inferior to the DES in TLF with a favorable low event rate. The Dynamics has demonstrated superior restoration of vessel motion and function, the restoration of pulsatility, lower late lumen loss, and a very thin and uniform knee intimal coverage. And it looks like plaque stabilization and even regression is possible with the bioadapter compared to the Onyx DES, perhaps due to a synergistic effect of lipid-lowering therapy and also this restored vessel motion, function, and coronary flow. Thank you very much for your attention.
Thank you very much, Dr. Johan. That's an amazing view for the study. The result is superb. What do we need? The question for this, what do we need? Further data to be translated into a practical use of this stent. What do we need more for this stent to be out in the market strongly and compete with other stents?
Yeah, that's an excellent question. Of course, this is the first randomized controlled trial. There's data coming from the Sweetheart study with 2,500 patients, so I think that will add more data. And of course, it's the long-term follow-up we want to know. We want to know how this translates to clinical endpoints. So I think at 1 year we can see here already a lower TLR rate. So I guess this needs to be confirmed over the next number of years and in larger studies as well. But I think it is very promising. And certainly, I think very exciting to see this technology.
I'm glad that you mentioned that, Dr. Bennett, because I don't want to be the skeptic here, but if we remember the story of the bioabsorbable scaffolds, and that's the ultimate uncoupling and restoration of vessel pulsatility, there was a lot of promise, and eventually we learned that technology was not perfect and ultimately failed. So this is very encouraging, but I really do think before we start talking about widespread use and marketing and this thing, we need to have more data to really show that this does positively affect hard clinical endpoints with long-term follow-up rather than theoretical improvements in vessel pulsatility or endovascular function or what have you. So I think a word of caution here. Shouldn't be rushing into this. This is very exciting and a very promising technology, but I think we do need to wait to have a greater number of patients, more follow-up, and especially a translation of these theoretical benefits into improved patient outcomes.
I have two questions. Then I will handle the discussion to Dr. Nawfal Anizi. For you, Dr. Khalid Al-Shaibi, the bioresorbable was an excellent technology, but it needs a lot of work by the interventionist to optimize that stent. Probably if we use more IVUS and OCT at that time, and we use the stent in a proper fizzles, maybe the result was much better. But what do you think? This stent, you don't need all this technicality like to use it compared to the bioresorbable. What's your comment on that?
Well, I'm not sure that statement is necessarily correct, because I don't know, Dr. Johan probably can answer this question. In this study, was IVUS or intracoronary imaging used to deploy both stents? If it wasn't, you could argue that maybe if you had used intracoronary imaging to optimize your regular DES stents, you'd have had better results.
Yeah, I mean, I take your point. I think imaging always improves, especially in complex lesions, but also I think in simple lesions can improve our outcomes. So out of the 450 patients, 100 patients had imaging, so in 50 in both groups. In both groups, 50 in both groups. So a large majority did not have any imaging. Having implanted quite a number of these patients with the bioadapter, I must say it really, in your hand, it is a metallic DES. It's in terms of crossability, deliverability, visibility, all these aspects which make it very easy to implant. And I think which also lead to probably better results. You're not spending too much time having to do all the preparation. Of course, pre-dilatation was compulsory for all patients. Post-dilatation was left to the discretion of the operator. Imaging helps. I think in this simpler lesion subset, I think imaging might have caused a much better outcome. I think you can see outcomes were very good. So it's a different animal than the BRS, which of course we also planted lots of those ourselves as well. I think the nice thing is here, you don't have the positive remodeling, which really was Achilles heel, I think, for the biosorbable scaffold, because the vessels enlarged and this polymeric backbone was left intraluminal. We will not see here, I believe, but I think we have to wait to be sure about that.
I'm not. Don't get me wrong. I'm not trying to put a damper on things, but I mean, I get a little bit worried when people start talking about, getting it into the market and start implanting it when we don't really have all the data there. That's all I was making. The point I was trying to make.
If I could just make a really quick comment here is, I think we're drawing too much of an analogy to the bioresorbable stents, although the technology is quite different. But I think the comparison in terms of not jumping too quickly, waiting for the evidence, etc., that's probably where we should go. But I just
that's absolutely what I meant.
Yeah, I just want to make sure people recognize that this is not the same kind of technology. It's not a magnesium stent. It is not a bioabsorbable scaffold. But one thing in your conclusions that caught my attention, and I would like to emphasize, is that you did mention lipid-lowering medications and so on. So whatever we do mechanically in the artery really complements what we do outside the cath lab, which is medications and lipid-lowering. Quick question, maybe I missed the slide. How many of the patients actually had an acute coronary syndrome, and how many were just stable angina?
I think the majority were stable angina. I think between 20 and 30% had acute coronary syndrome. So non-STEMI or unstable angina. STEMIs were excluded from this study.
So we are being cautious in how we unroll the technology.
Absolutely, I think that's vital. And I think from the evidence you're looking at also, implanting the McMars and taking part in studies there, I think lipid-lowering therapy is really vital, to try and get the LDL down as low as possible for all patients, and especially also in this novel technologies.
We did have a few questions to Dr. Colombo, I think, from the attendees, and he answered most of them, I think, through his presentation. However, there's one question regarding the role of bioadapter in bifurcations and trifurcations.
But we have an ongoing registry in Humanitas where we use these bioadapter in complex lesion, including CTOs, long lesions, bifurcations. And we did not use this device in a bifurcation with two stents, with two bioadapter. We have used it in regular bifurcations with only side branch dilatation, but so far we did not encounter any problem, and I do not believe you cannot do mini crash or culotte with this device. So acutely, this device behaves like a metastent.
So, Dr. Khalid, I get your point of waiting probably on using such device until we have stronger data, but do you think it is worth starting using this in some of our population, given that we do have much younger patients, especially those who have like single vessel disease, who know diabetes, very straightforward, simple PCI type A lesion?
I would strongly support that it was part of the global registry.
Yeah, I think if we do that, we need to enroll this patient in a prospective registry. This patient cannot be missed. They have to be linked like a special person, and they need to be followed.
Yeah,
Absolutely.
We will work on that together, Dr. Colombo.
But honestly, I like the idea of young patient, but I think we should enroll the most complex patients, because that's where we need. Because in type A and simple lesions, almost maybe even a bare metastent does well.
Anything works. That I get the point of post-marketing surveillance. I think the uncoupling also is attractive in tortuous vessels. the concept of it and so on. And that just may help kind of restore the normal flow instead of having a metallic tube that just changes the dynamics of the vessel.
Yeah.
Do you think we should move on to get the real world experience from?
Yeah,
Okay.
yeah.
I'm,
we
I'm,
got-
I'm sorry, I have to leave. I expected 1 hour, so I hope I answer my questions, and I wish you all the best, and thank you for this opportunity.
Thank you, Professor Colombo, and hopefully we'll see you soon in another meeting. Your presence is always valuable, and hopefully we can do the work together on this stent.
We must.
We'll
Thank
get
you.
in touch with you. Thank you. So
Thank you.
without further ado, we're gonna move to Dr. Samih, senior interventional cardiologist, well known in Saudi Arabia, to give us a practical example. Dr. Samih?
You're muted, Dr. Samih, if you could unmute.
Sorry. Okay, thank you for inviting me to talk about our what I call limited experience. Over the last 4 months, I intervened with about 14 patients, did I connect well? Do you see my screen?
Yes, we see the screen and we hear you clearly.
Excellent. Okay. So without undue delays, I elected, of these 14 patients, I selected 5 patients randomly, but assuring that I'll get different scenarios. So this is my first patient, the 69-year-old male with chest pain and history of having had recent car accident, multiple rib fractures, complicated with pneumonia, and upon arriving, we had increasing troponin, and her ECG showed left bundle branch block. In the ER, my team was invited to assess, and we discovered that the ejection fraction was 30 to 35% with grade 3 diastolic dysfunction. As a result, once we felt the patient was stable, we took her to the cardiac cath lab, and we found the following. Totally occluded LAD proximally with calcification, 50 to 60% mild bifurcational OM and AB group LCX, RCA mid-third, and RPDA bifurcational with the RPLV 80%. And here we are dealing with a heavily calcified LAD and also RCA. And I use bioadapters for this situation. Where are the images? Oh my God. What happened? Is there a problem here? Just reviewed it just before the presentation. What could be, let me go to the full.
Can you press the play button at the bottom? There's a small arrow there. If you hit it, it might work.
Play here, I mean.
Cannot play media. Okay.
Wow. What could be done? I have never seen this in my life. Let me stop sharing and I'll come back to you.
Maybe this was, were you using
Do you have an idea?
Were you using a regular PC and now you're using a Mac?
No, I'm using my regular PC. And it's all in the manner that I used when I prepared it. Resume slideshow, maybe this one. I have no idea. Let me close and reopen.
Meanwhile, we can take questions from the
Yes,
audience.
please. I'll
Dr. Yohan, there is a question regarding the antiplatelet therapy. What is the protocol with this kind of a stent?
Yeah, well, for the randomized controlled trial, it was minimum 6 months antiplatelet therapy. So of course the ACS patients got a year, but it's according to current guidelines. So 6 months is absolutely fine. It's also a thin strut, Des, so there's no concerns really about increased thrombosis risk or whatever. So 6 months.
I have a question if you allow me, Dr. Weil.
You are the chairman, Dr. Adel, so you can ask anytime you want.
Thank you. Thank you very much. I have a question for you, Han. Now, if you are advising a policymaker like in Saudi Arabia on we need to start using the bioadapter and we need to register in a global registry. So he will ask a question. What is the percentage of patients, first of all, that will receive this stent, because there is a financial burden or a financial increase in the budgeting department? And what are the criteria of patients initially in this very early stages of using this this new novel technology? What would you advise?
Well, that's a difficult question for me. I think the study coming out shortly from Sweden with 2,500 patients, it was an all-comer study. So patients had long lesions, bifurcations. I don't think left mains are CTOs, I'm not sure. The study I presented there really was this typical stent, first randomized controlled trial, quite controlled, shorter lesions, no severe calcification. So therefore, what percentage would it be of my daily practice? About probably 20% will fulfill my daily the criteria for the study in my patients I see every day. Though, I would kind of disagree a little bit with Professor Colombo in that I think young patients have got probably the most to gain from this, because if you have a 40-year-old diabetic, you hope he lives another 40 years, and if he gets a standard metallic DES every year, there's a 2% chance of a stent failure. So I think in those patients, you could save costs of readmissions, of myocardial infarctions, revascularizations, need for CABG. So I guess my focus will be on the younger population. And then we can move on to the complex lesions as well. But that would be my thoughts. My target would be the younger patients, which I think in your case is quite a large percentage. I mean, my patients are majority 80. I had a 93-year-old. I just did a CTO on this afternoon. But so it's a very different population group than what perhaps you treat. So I would focus on younger patients and aim to, that of anti-lipid therapy, dietary advice, be the main issue to try and reduce the healthcare burden, which I appreciate from the first presentation are quite large in Saudi Arabia.
Yeah, I think I was amazed from your presentation by the concept of plaque regression and non-calcified lesions. So I think maybe we could start our program in Saudi Arabia on younger patients, diabetic, non-calcified vessels, that we could put these stents that they would provide more longevity, theoretically speaking, and the possibility that in those younger patients with less calcifications would have plaque regression.
Yeah, I would fully agree. Absolutely. And I think if they are diabetics with high lipids, they will have lipidic arteries, and the long lesions did very well. The LAD did very well. So I would focus on those patients with long LAD lesions, not too calcified, as a main target.
Yeah, I think the answer to Dr. Chebby's very important question on how to really start and introduce the bioadapter to our local market is through two routes. First of all, we be part of that global registry. We have initially criteria that would, these are the patients that we are going to treat. Those patients would comprise around 10-15% of the total burden of PCIs done in the kingdom. And the other path is the clinical trial path, where we do a proper clinical trial protocol and start working on until we have, as Dr. Shaibi mentioned, that full-fledged picture with different patient categories and different patient characteristics, different presentations, because most of the cases that were done globally, I think, are on stable angina patients. So I think that that's a careful way of navigating the startup of such a novel program in Saudi Arabia. Would you agree, Dr. Shaibi?
I absolutely agree. I think if we're going to use it, it should be in the context of a registry, whether it's a global registry or local registry, or in the setting of a randomized clinical trial. I don't know, but this question I'll ask to Dr. Bennett. Have you implanted any of these bioadapters outside a clinical trial?
I have not. I have not, because again, the reimbursement issue in Belgium, etc. But I think, like any new novel technology, putting them in patients into trials, it gives you protection. It gives the patient, okay, I'm being followed up here. And that was the mistake, I think, with the Absorb story a number of years ago, where we were almost
absolutely,
if you don't implant it, you're committing a crime. And I think that was the issue with it. So I think controlled environment, and then you gain experience, you gain confidence. And then I think, of course, that the price should come down as well of this device as well. It was being used more and more, and there's lots of safety data on it. So that's what I really would recommend. Yeah.
So we will go to Dr. Samih. He's ready. Dr. Samih?
I'm available. Okay, ready again.
Yeah. Let's start, please.
All right. How can I share here? I do not have the main screen anymore. Do you see my share, my shared screen?
No, we don't, Dr. Samih.
Well, how do I make? I don't have the what you call the.
Slides on.
How do I reconnect?
You see the green share screen in the bottom?
The bottom, there is share.
There is nothing in the bottom. This is why I'm saying, why am I, as if I am not connected? I am rejoining. I don't know.
اوكي دكتور اخرج من هذا وارجع ادخل ثاني.
شكله هيك.
Dr. Bennett, we do have a question, I think, from Dr. Abdullah Shahab. He is asking for your opinion regarding bioadapter compared to drug-eluting balloons.
Yes, I guess both of them are a hot topic at the moment. We're using more and more drug-eluting balloons as well. So yeah, I think it's exciting as well in bifurcations in small vessels. So yeah, I think there's also a role for them to play. Obviously, there's been no comparison between the bioadapter and DEB, and Professor Colombo was alluding to that, to try and compare a metallic DES to bioadapter and a drug-eluting balloon. So I think it's a very interesting concept. I think for me personally, in the proximal LED, I always like to have a nice acute DES-like result. It makes me sleep better at night. But I think for small vessels, bifurcations, there's certainly a role to play, and that is increasing as well for drug-eluting balloons.
Is there anything in the horizon to compare it to CABG? Is it going to settle the debate between us and CABG?
You mean for drug-eluting balloons, or you mean for the bioadapter? Well, I think that was one of the things we were discussing. I think that would be an ideal, as a Lima LAD or a bioadapter in the LAD. So I think these are interesting concepts which we have to explore.
I'm ready.
Maybe Dr. Samih, if you, sometimes it doesn't work on presenter mode and it works on the regular mode, but let's try it again.
Okay, this is regular mode, so let's see how it works. Do you see my screen?
Yes, we do.
Okay.
Yes, it's
All
working.
right, this is the finding of the patient left anterior descending, totally occluded, subtotal, you may say, with the circ having mild bifurcational lesions. You will see my attempt to go through initially not hitting the right path, then hitting the path with the support of a small balloon, then crossing with a hard wire, and then exchanging my wire and then pre-dilating, and again pre-dilating and pre-dilating. And this is what I got. You can see now the extent of calcification. This is my imaging technique to position my bioadapter stent, and then my optimizing technique using stent boost to support the proper deployment. And I did not show you all the balloonings for sparing the time. And this is again improving further until I believed that I had an excellent result. And then I proceeded to the right coronary artery where there were bifurcational lesion and proximal lesion. The bifurcational at the crux, I started by dilating the branch. You can see that the balloon had difficulty opening, then dilating the main, then stenting with a bioadapter, and then using my technique to optimize the stent, and then putting a stent in the mid lesion, proximal to mid, and you can see easily how calcified it is, and optimizing, and finally getting this result. And you would notice uncompromised right PLV branch, telling you how it respects, I call it, it respects the branches. This is my real case, 33-year-old male who presented with non-STEMI with a 3 days history of chest pain, no risk factors. I just heard yesterday his LP little a result, it was 122. No family history, no risk factors, no nothing. He is only a vape smoker. Whether vape is the reason, I don't know, but I know that this is what I have. Multi-vessel calcified, all calcified, anywhere from the LAD proximally to the proximal to mid and subtotal calcified RPDA of the right coronary artery, and also mid LCX. Now we'll go through how I managed this patient with and having a problem that developed while putting stents. I called it the sliding stents. This is his this is his left system. You can see the proximal LAD lesion again. And this is the ICA, proximal, mid, and mid PDA lesions. And started by dilating, and it was extremely hard to cross the mid PDA. You can see this is the smallest balloon I've used, 0.75 diameter. And this is the only one that crossed. And when I opened it, it did not open enough. Anyway, eventually I managed. And I opened with several balloons. I did not show you all. And then I dilated the proximal, and then decided, after finishing the PDA with a coated balloon, I put a stent in the mid vessel, mid RCA, mid third. And then my aim was to put a proximal stent with a separation between the two stents ranging around 6 to 7 millimeters, which is reasonable. But what happened, this is exactly what happened. I tried to put the stent, but I noticed that the guider was moving back and forth. Typically, sometimes you see this phenomenon with the right coronary artery. And you can see there was a distance between the stent and my initial assessment. But once I decided to deploy it, the stent and the guider slided down by about 5 to 6 millimeters. And that you can see here, this is in reverse. This is how it started. And then if I go back, I can show it to you. Okay, this is the after sliding. And when it slid, it actually hit the second stent, which was not intended. Anyway, eventually I had to put a proximal stent, and again, I faced exactly the same problem. And here I had to use my technique to support my advancement without sliding. So I actually managed to get the guider and the stent one unit touching each other so that I could support positioning it as it is here. And here I decided that it is ready to be deployed and deployed properly. This is the findings. You will see calcifications. You will see this post-dilatation, and this is what something probably should be observed. Calcium at the ostium of the vessel, and this could have caused the sliding of the stent. That's my own theory. Anyway, eventually the result was remarkable, although at the expense of 3 stents instead of 2. The mid PDA was done. Then I did the LAD, and my observation is that it also protected the side branches. You can see the calcium. It took me several attempts to open up, and you see the last image is opening up nicely. And this is the result. And this is my next case, 55-year-old male presented with worsening angina in OPD, diabetic, hypertensive, dyslipidemic, CABG remotely, ischemic cardiomyopathy, again, was treated in another hospital, then came to us with an ejection fraction of 35%, previous PCI to CTO RCA plus 2 DAS, findings, ISR mid-instant RCA treated with 2 DEB. You will notice my DEB rate is high. Patient Lima, severely diffused. Lima is patent, but the vessel is miserable. You will see how it looks. Diffusely from the joint, from the joint point where the Lima connected with the LAD all the way to the apex. There was a left main disease, but because of the Lima is protecting and the SVG to OM was protecting, I considered there's no need to interfere, and there was occluded SVG to the RCA. This is the LAD. As you see it, that's the best of what it can be. Usually disease, and the patient was very symptomatic. So I had to interfere. My aim was to put drug-eluting, drug-coated balloons only, but not all what you plan will go the way you like. So here, although initially I thought that's still reasonable result, but I started feeling that there's something in the middle evolving. So I decided to treat the distal area with the drug-coated balloon, the smallest I had, 1.5 actually. And then I went to proximally to it. Your images are in the middle, but anyway, I discovered that the mid vessel is dissecting, and it may become worse after the drug-coated balloon distally. I ended up putting a bioadapter 2.25 millimeter and deployed, and then you will see. And then this is how it looked. Needed optimization, that I did, because again, maybe fibrosed or somehow calcified. And then ended up with another drug-coated balloon all the way to the anastomosis, and final good result. Then this is my 75-year-old female presented with ACS, pulmonary edema, and pneumonia, AFib, hypertension, diabetic, managed medically for 1 week to manage her pneumonia, and then taken to the cath lab. Her anatomy will show you later, but I'll summarize it. Small caliber LCX, Ramus, and RCA treated with 1S 2DEB, bioadapter stent to proximal LAD, respecting all small disease diagonals, and course was complicated with recurrence pneumonia. Eventually, patient recovered without cardiac events. And this is her anatomy. It's hard to see the LCX is smallish, the LAD proximal lesion, and you'll see it better here with two diagonals emerging in the same area. And this is the right coronary artery, small caliber, subtotally occluded distally. And then I started by opening up the diffusely diseased LCX, aiming at putting drug-coated balloon only, but it didn't work the way I like because there was a dissection at the area, particularly more distally. I ended up putting a long stent. I call it a tapered stent. It's an Indian stent that is smaller distally than it is proximally, and then it gave me a good result. This is how the stent appeared after optimization and with good result. This is the drug-coated balloon to the OM, good result, and then LAD. I put a diagonal branch in order to protect it, and put my bioadapter, optimized again, and this was the result. And you will see no affection whatsoever to the branches. Then I did the PCI with the DEB only to the distal RCA, knowing the size is small. And this is the DEB positioned, and this is the result. This is a 64-year-old Canadian male presented with left arm pain and dyspnea. Past medical history of having had an acute MI while serving in Vietnam. In 2020, he developed a STEMI and then anterior STEMI. And at that time, they put two consecutive stents all the way to the distal third of the left main. He's hypertensive, just like
if you don't mind.
Positive nuclear stress test that I did because of his left arm pain turned out to be fixed in the anterior area and posterolateral ischemia, indicative of perhaps CIRC or right coronary artery involvement. And this is the findings. You will see, I'll show it to you. Initially, I thought not much there, but I looked carefully into the ostium of the CIRC to discover that the ostium of the CIRC is definitely diseased, and I had to do something about it. This is the LAD and the stent area, and this is the RCA. It looks extremely good. Now, I did IVUS to the CIRC and IVUS to the LAD. This is my CIRC IVUS. I will just jump to the last part so that for saving time, let's put it here.
Yeah, Dr. Singh, we're going to have to really speed up a little bit.
Yeah, I have only 1 minute maybe. This is the now at the near the ostium, calcified, eccentric, and you will see that at the junction, the stent is malapposed. And here I calculated the area showing significant stenosis. And this is the part within the left main itself. And this is the LAD IVUS. You see very badly malapposed, especially with the more distal stent on my left-hand side. And then on my right is the junction, what you call the overlap area of the two stents. And this is the ostium of the LAD. So the ostium of the LAD was okay. And this is, I started my procedure by advancing my balloon, which was difficult to enter. I had to use a small balloon. And then after positioning, and again, look at that. Very hard to open. It eventually opened. Balloon was sliding also. There's some improvement. Then I had decided to stent, and you'll see the positioning of the stent using the double technique, and then deploying hard, opening, and then here when I tried to do the first kissing, the LAD balloon, the left main LAD balloon slided. So I had to repeat it again later. Anyway, this is repositioned and then followed by dilatations within the stents where I thought the stent was under deployed, malapposed. And this is my drug-coated balloon. And this is my post-dilatation technique, sequential. Then I planned my simultaneous techniques and aimed at this result. Patient is doing well, and I've seen him twice since he left the hospital. In summary, what I think is that these different scenarios represent a stent that is easy to use, that is conforming with the vessels that I treated beautifully well. Many of our patients have calcifications, and with the imaging technique that I use, I managed to optimize the stents. I've had no complications of all the patients, of the all 14 patients, but this group of patients that I selected represented the different scenarios that this bioadapter can be used in. And I think it has a special protective element towards side branches. This is my initial impression. Thank you.
Well, thank you, Dr. Samih, for giving us a real-world data or real-world experience. I am optimistically cautious, like Dr. Khalid Al-Shaibi. I think we do need to take it step by step before we do it in bifurcations, in-stent restenosis, left main disease, and calcified lesions, because at the moment, these are considered off-label and they're not part of the randomized data. Although calcified, for example, somebody had it in the questions in the Q&A, that calcified was moderate to severe in the initial 2020 feasibility study. But remember, that was just a feasibility study with 50 patients and 1-year outcomes. So I think the messaging here is that if we're not going to be doing it in a randomized trial, we probably should be doing it in post-marketing surveillance registry type. We probably should be doing more intracoronary imaging to kind of guide us on selecting the patients. And a final comment about, using it with drug-coated balloons. I think you showed us a couple of examples where, yes, you go in with the intention of drug-coated balloon, but you have to have a plan B in mind. That drug-coated balloons are not the albeit answer. You may have flow-limiting dissections and so on, and you need to be ready with a stent, albeit bioadapter or a drug-eluting one. But we know what we need to do. We need to work on primary prevention, not just secondary prevention when they end up in the cath lab. And even when they end up in the cath lab, we need to couple it, as Johan mentioned, with intensive lipid therapy, dual antiplatelet, lifestyle modification. So thank you, everybody. And Dr. Adil.
If I may just say one word, the issue of finding coronary arteries in Saudi Arabia without calcifications is something to have to think about, because I would say 70 to 80% of our patients do have calcifications. And to select these targeted patients without diabetes as well are rather few.
Yeah, absolutely. And I hats off to Dr. Tash for sponsoring a consensus document on management of calcified lesions in the kingdom. And the draft is almost ready for publication. We shouldn't overestimate calcification. Fluoroscopy is definitely important, but intracoronary imaging, particularly if we're going to go for atherectomy. And stay tuned for that one.
Okay.
Thank you. So
thank you.
In conclusion, guys, a promising technology. Probably the best will work at the beginning in simple lesion in young population. We'll be happy to participate in the registry part of the war. And with that, we're gonna thank Dr. Adil Tash, the National Heart Center, for this great opportunity. All the esteemed panelists and speakers. Really, thank you very much, and wonderful meeting. We have to stop because we exceed the time, and thank you very much. Thanks a lot.
Thank you all for this enlightening meeting and very great presentations, and looking forward to seeing next steps or deciding next steps forward. Thank you very much.
Thank you.
Thank you.
Thank you very much. Have a nice evening.
You too. Bye-bye, guys.
Bye.
Bye.
Thank you.